when you're looking at the closed loop data outputs, what are the sort of like things you're looking for? Like what goes on in Ann Peters' head that might be useful for providers listening to kind of think about as well?
Well, I think the first thing I need to know, nobody ever gives me exactly what I need, but the first thing I want to know is how is the user using the devices? Because for instance, and I teach this to my fellows, I want to see how often they're making infusions that, changes so that I know that they're changing it often enough. I want to see that they're, how much they're using it in manual mode, how much they're using a bolus calculator, how much they're overriding it. I want to see what a person is doing so that if a person's only doing manual boluses and they're on a system where they're supposed to be using some sort of bolus calculator, then I know that changing the bolus calculator doesn't change anything. So I first want to see how well the patient's using the system. And that's especially true in my East LA patients where they don't really focus on the details. And I have patients there on pumps now. Ever since the Affordable Care Act let my patients get better insurance, I've had more patients on pumps. So in the past, they would recycle pump supplies and things, and they would, use the infusion set for a week, and it would cause all sorts of problems. But I do that, and then I want to get an overview, right? The modal, this, whatever the graph is. And I look at the AGP now just because I've learned it. In the beginning, I balked at having anyone tell me what to do because, that's not my forte. But I look at the AGP because it gives me a sense of patterns. And I look at all of the parameters that I think are important. So time and range to me really matters. And then I look at how much is below 54, how much time is spent below 54 and 70, and how much time skews high. And then glycemic variability really matters to me because I think it matters to the lived experience of people with diabetes. So I want people to have as, small a coefficient of variation as I can and try to help them get there. But then I look at each day for 2 weeks and I want to know what happened each day because that the AGP is just an amalgam of all of that. And I want to know, what days of the week are you working out? What days of the week are you going out with your family? Back in the old days when people used to go out. But, what's different? It's actually much easier to manage diabetes without people going out all the time. I'm just pointing this out. But I want to know, and then when I see an off day, I want to know what made that day different. And so by doing that, I actually learn a tremendous amount about people's lives. And I say to people, they can't hide from me, right? Because I know by their glucose profiles, and I can actually look, and I know my patients so well, and I actually know their glucose profiles so well that I can say, my gosh, you've been really stressed this month. What's been happening? And, usually I'm right that the profiles really do reflect what's going on and that there's some sort of interplay. And so I think looking at the days for me makes me understand my patient more. And it's not just one, oh, gee, we've got to go up on this dose. It's more of a, maybe when you're just before your menstrual cycle, we need to do this, or maybe when you're going out and playing basketball on the weekends, we need to do that. So to me, it's the drilling down of it. And as a provider, I know that there's a lot of effort to try to simplify the interpretation of the data. And for me, that's annoying. Nothing personal against people trying to simplify, but I actually, as I started out this whole thing, I like looking at the granular day-to-day data. But I think it's hard in terms of simplifying because, again, it has to do with what did someone do this day? Did they eat late? Did they, I don't know, run to catch a bus? Did they bicycle to work? It's hard to always know because nobody's tracking it. I mean, I guess we could put activity trackers on everybody. You could get a ton of data, but in the real world, that's kind of hard to do. But certainly, I think going back to it, as I look at how is the device being used, and then I look at how successful the person is and what are their trouble spots, and the AGP tells me that. And then I look at the days to give my brain an idea of what I might need to adjust. And then I work with, obviously, the patient to say, maybe we need to do this, or maybe you're giving your pre-meal bolus after the meal or during the meal, and that's leading to hypoglycemia. And, I look at that. I look at all the fine tuning that a person does. But then there's that whole analysis phase. And this is why I can't do it quickly. And this is why I can't do it while writing, is because I have to think. And it's, subtle stuff often that makes all the difference.
Yep. Yeah. I like the way you describe that too. It's almost like you try to get like a whole context around someone's diabetes by like looking at the big details, and then you kind of narrow and focus in on each day to kind of add color to the context.
Well, yes, and it's all about also people, you know, we like to please, right? I mean, I want to please my doctor, you want to please your doctor. And I think part of it is people get like embarrassed, like, oh, gee, I went high that day. And it's like, yeah, you're going to be fine. And, you know, I think that there's also a comfort part to it. And so much of what I do now is to really tell people they're going to be fine, because they are. And,
Yes.
you know, it's also really hard, as you well know. But I think that there's a positive part of looking at the data, like, gee, look at how well you did and look at what worked, as much as it is what didn't work. And I think that that's obviously something we all need to do, because if you just look at what doesn't work, it gets really negative.
Yes, totally. I also find that a lot of people, when they're new to CGM, feel like the numbers are grades or judgments on them as a person or as a parent. And sort of decoupling those two things can be really powerful. Like, this is just information to help us make decisions. And that, like, tidbit alone, I feel like can transform people's whole mindset around it.
Well, yes, but I think that holding people to a numeracy standard is tough.
Yeah.
So that, you know, everybody wants to promote time and range, and I get that. But if you're a patient and you don't either have the skills to do it, to keep yourself in range, or you don't have, frankly, the healthcare providers to help you, if you don't have a diabetes educator or someone around who can help you do this, it gets really frustrating if you know the concept, but you can't get there. And, you know, I think that makes people just want to give up. And I think that time and range, first of all, by and large, requires CGM. But second of all, I think it's like time and range, and then what? Time and range has to be coupled with action. That you have somebody nearby who can help you get there. But I don't want people to get discouraged. And that's one of the problems with putting CGM on people, is that they look at the numbers and they don't know what to do, and they get really discouraged. And it's just not as simple as putting a device on someone and letting them get better. That doesn't happen. I mean, I have patients who get better all the time on CGM, but it's because they have knowledge. You have to apply knowledge to improve your diabetes control. CGM does not magically come with knowledge.
Right.
I mean, it's data. Data is data. You can have data and have high sugars. You can have data and have low sugars. I have people who have low sugars all the time, and it makes me insane. And the data's right there, and they don't change their behavior. So, you know what I mean? It's got to be coupled with knowledge.